Hello and welcome. We're thrilled to see so many of you join us here today for the live webinar, The Mobile RA, using handheld ultrasound to guide Pec and supraclavicular blocks plus intra-articular injections. With over 1,600 registrants for this webinar, ultrasound for guided injections is certainly a hot topic amongst anesthesiologists and pain management experts. Welcome to all of you joining us from all corners of the world. Today's guest speaker is Dr. Greg Hickman. Over 30 years, he's perfected the art and science of ultrasound-guided injection to deliver maximum pain relief. Today, you'll learn his master tips for using ultrasound for fast and effective regional anesthesia procedures. We'll hear from Dr. Hickman in a moment, but first let me introduce you to your host. Dr. Aron Frankel is trained in emergency medicine in California, has been using point-of-care ultrasound his entire career, and is a passionate POCUS educator. He now practices in a busy academic teaching hospital in Vancouver as an emergency physician. When he's not saving lives, Dr. Frankel also serves as chairman of our Clarius Medical Advisory Board. Welcome, Dr. Frankel.
Thanks, Janez. It's always good to be here. And today's topic is one that's near and dear to my heart because regional anesthesia, I think, is in the core skill set of people using point-of-care ultrasound for procedural guidance. So for some of the background of today's topic, before we get to Dr. Hickman, we did a bit of a literature review, and I wanted to just review some of the findings to set the stage for our discussion. You know, the question that really comes up a lot from the anesthesia literature and from our colleagues is ultrasound guidance now the standard of care? We know it's kind of been around for almost 25 years now for guiding regional anesthesia. And it's no surprise to all of you that ultrasound guidance for regional anesthesia has gained enormous popularity in the past decade. And every 5 years, as more and more research comes out, it seems to be exploding both with the techniques available and the applications and the research on its use. And it's become basically common in daily practice, as we know from this one review article, and the number of practitioners using it worldwide is increasing day by day. You know, but the best data we have, I think, comes from the ASRA reviews, and they've done two now. They did one, the most recent one was published in 2016, and they assembled an expert panel to give guidance to basically review the whole field of literature of studies that have been done as a really rigorous systematic review. And the expert panel found a couple really interesting findings on their last publication. First, as we know, it backed up the finding that ultrasound is rapidly becoming the default nerve localization technique. It's really the standard way that people are learning to find the nerves in the body and identify them, especially for novices and trainees during their educational period. Next, what's more interesting is the findings that are becoming more and more rigorous in the data, that the use of ultrasound hastens the onset of sensory and motor block. It decreases the performance time, the time to produce and get your block into the patient, and it results in fewer needle passes because we're visualizing the needle. All of these we would think would translate into obvious clinical benefits for at least the anesthesiologist and the patient. And when we dig a little deeper to look for, are there outcomes, it's quite definitive at this point that the use of ultrasound significantly reduces the risk of LAS, local anesthetic systemic toxicity, which is, of course, the most feared complication of regional anesthesia, whether you're doing it blind or with image guidance. And so even this alone starts to prove that ultrasound is really making a dent and an improvement in clinical care. It's important to note that LAS still does sometimes happen even with ultrasound guidance, but the incidence is significantly lower. And also what was interesting to me was to learn that, especially with the upper extremity blocks that Dr. Hickman is going to be talking about, the incidence and intensity of hemidiaphragmatic paralysis is reduced with ultrasound guidance, probably as a result of being able to use smaller amounts of medicine and lower doses because it's more targeted injections. And so the question comes up, is it standard of care? The ASRA paper stops short of calling it standard of care. And one of the things that was pointed out by one of the commentators was that the lack of available ultrasound machines at all locations limits the ability to call it the standard of care, which is a fair point. But now we're coming, you know, this was last published in 2016, it's 5 years later. And here we are now with handheld ultrasound probes. And this new generation of point-of-care ultrasound devices really makes it much more accessible to practitioners everywhere. And despite what we think are proven benefits of using point-of-care ultrasound imaging and bedside ultrasound imaging, adoption of the technology is still not completely widespread among anesthesiologists, and nor is there uniform teaching of ultrasound skills to anesthesia residents and faculty and staff members. And one of the obstacles that have been identified over and over is that precludes the achievement is the availability of equipment. This comes up all the time, and the lack of supervision and training that's available to the users. And not everyone has an instructor knowledgeable in point of care ultrasound or bedside ultrasound with them whenever an ultrasound examination or a procedure is warranted. So we think that handhelds really can produce the transition of care and really set the standard in the coming years. And we're so happy to have our guests here to give us some guidance and promote this educational facility on how to use these probes and do the blocks. Before we get to the excellent content though, we want to run a couple quick polls just to see where our audience is and where you guys are at. We're spread out across international borders. There's people from all over the world at different skill sets, skill levels coming to this webinar. So we want to know first, do you use ultrasound to guide procedures? Give us a sense of where it is in your practice. Do you use it daily, occasionally? Are you hopeful and curious about using ultrasound? And are you planning, or is it just something you want to learn about? So we'll give you a couple seconds. This one's a quick one. Great, let's go ahead and we'll close out that poll. Let's see where people are at. Okay, so we have at least a third daily users, a third occasional, and maybe a third curious and hopeful. That's perfect spread. We have the exact content to meet your needs of beginner, intermediate, and advanced today. So that's great. And finally, with the handheld probe revolution that's coming is what we talk about it as. We're curious what features would be important to you as an anesthesiologist, things we can highlight in the webinar maybe about where that it can follow you in your practice. Because as Dr. Hickman's going to show us, it's not just restricted to the operating room. These probes allow us to take and do procedures anywhere within hospital or outside of the hospital bounds. And so which of these are most important to you? Is it portability, that it's affordable and something that you can buy on your own budget? Is it the clarity of the image so you can see your needle and your targets? Do you want it to be really easy to use? Is cloud archival and sharing of images at all important to you as an anesthesiologist? And are you interested, at least on the educational side, either learning or teaching others with teleguidance or obtaining training on how to use them? So curious to see where people are at. We'll give you a second. Click all of them that apply. Okay, and we'll go ahead and close that one out. Okay. So image clarity, number one, no surprise there, especially if you're guiding needles towards, as we're going to see, pretty close to vascular structures. Really want to know exactly where your needle tip is as number one. And then I would say the close seconds is being easy, portable, and affordable. These are pretty resonant across all clinicians, across all professions, and all specialties. So this all makes sense and kind of matches where we're coming from. And who better really we can think to help us learn a little bit more about how to use the ultrasound for both beginner and intermediate and advanced blocks, and then Dr. Hickman. Dr. Gregory Hickman is the medical director and anesthesia director at the Andrews Institute Ambulatory Surgery Center in Gulf Breeze, Florida. He's certified by the American Board of Anesthesiology and the American Academy of Pain Management. He's licensed in Alabama, Tennessee, and Florida. Dr. Hickman is also co-founder of the popular ultrasound-guided regional anesthesia education website, blockjocks.com, which teaches doctors, nurses, and patients around the world. And I might add that Dr. Hickman is a double black belt in ultrasound-guided regional anesthesia, and we're so happy to have him here today to help guide us here. Dr. Hickman, over to you.
Thanks, Dr. Frankel. I appreciate that kind introduction. Very nice of you. So I want to talk about my experience with the Clarius ultrasound-guided regional anesthesia, about using a wireless system and how we use it in our facility, the advantages, some of the things we can do, and talk about a couple of blocks that we do here. As you can see, our introductory slide shows you the beautiful Andrews Institute down here in Gulf Breeze, Florida. As you can see, I got a little pointer here. The bottom floor on the left is our surgery center. The top floor is surgeons' offices. To the right is our research and education building. We have a restaurant on the top floor, an athletic performance facility in the right side in that building on the right, where athletes come and train in the winter. They do 6 weeks of combine training. College players come here and leave and go directly to Indianapolis for the combines. We have conference rooms on the far right and the cadaver lab upstairs. where we can do cadaver work there. And so I'm going to talk about supraclavicular blocks. That's a block that I can do in the pre-op area. I'm going to talk a lot about mobility with wireless ultrasound. I go into the operating room. We'll do intra-articular injections of the knee and talk a little bit about that, why we do that. And I've been doing those for quite a while. And then talk about a Pec One injection that sometimes we'll do in our PACU in the recovery room when patients are struggling in that scenario. So let's talk about supraclavicular blocks. Basically, a supraclavicular block, as we know, in anesthesia is a real common block. It's often called the spinal of the arm because it works on everything, the whole arm. It provides really rapid and effective anesthesia and analgesia for the upper extremity. One of the first articles I read on doing regional anesthesia for the upper extremities was doing shoulder surgery with supraclavicular blocks for analgesia postoperatively back in 1989. And I started doing interscalene blocks in 1990 for shoulder surgery. So a long time ago, but this is a block and someone asked me a couple of weeks ago, there was I guess he had read an article about using supraclavicular blocks for shoulder surgery. And I said, yeah, absolutely, it can work. It's effective. Interscalene is probably a little bit preferred for shoulder surgery at this point, but certainly a supraclavicular block is acceptable. So we'll talk a little bit about the anatomy of doing a supraclavicular block. We're looking at the level of the divisions, and you can see we're kind of right here. We're going to be right on over the first rib, so we're at the level of this divisions and sort of where the trunks divide into the divisions here. So you got the trunks and the divisions, and we're right on the first rib. Look a little bit differently at the anatomy here. First thing we're gonna find is the first rib and the artery. And when you see the artery, the anterior scalene is just anterior to it, and the vein, that's a subclavian artery, and the subclavian vein is just anterior to the anterior scalene. The plexus is coming right over the first rib, just posterior to the subclavian artery and anterior to the middle scalene. So if you come on up, you can do the interscalene block up here, but we're going to look at supraclavicular right here over the first rib and right before it goes under the clavicle. So if we look at an ultrasound image, we want to look right here. Dr. Frankel, you can sort of draw the first rib here. So you can see the first rib, and that's dark below the first rib. Perfect, thank you. And with ultrasound images, bone prevents ultrasound from going through it. So it's going to look dark, deep to bones. You see the subclavian artery here, and we'll see our plexus and nerves just to the lateral aspect of the artery or posterior. This is pleura down in this area, a little shiny, pleura that can be a little bit sparkly, and then it's going to be kind of gray beneath that. So we want to use our rib here to protect us from the pleura. And so it looks like the nerves look like a group of grapes. And so when you look posterior to the artery, you should hopefully see that group of grapes there. So some pearls on doing a supraclavicular block. One of the things we're going to do obviously going to do a prep. What we use is just a simple chlorhexidine solution, a little small prep. Utilize those. And I like to use a long needle. I use a 10-centimeter needle for basically pretty much all of my blocks. And what this does, this allows me to insert my needle 2 to 3 centimeters away from the probe. A lot of pictures you'll see the needle going in right next to the probe. I like to get a little away from the probe. That allows my needle to come in flatter, kind of parallel to the face of the probe. And this gives you a better reflection for your ultrasound image, and it makes your needle much more easily visible in that way. Of course, we want to make sure before you start introducing your needle that you flush all the air out of your line. We have a syringe connected to some tubing to the needle, and make sure all the air is flushed out, because you don't want to start injecting air into your image. It'll really mess up your ultrasound image. Now, positioning, as far as positioning go, we're usually, like I'm doing these in the pre-op area, and so I have them on the stretcher. I can raise the back of the head of the bed up about 30 degrees. Just gives you easier access to the patient. Make sure just have the head turned to the opposite side. We're going to work on the left side here. So we'll have the head turned to the right, and then gives us room to work with our needle back here. Now, the first thing we're going to do is identify the clavicle and the sternocleidomastoid. And what we're going to do is put our probe just posterior to the clavicle and aiming straight down towards the feet, down towards the toes, and just lateral to the sternocleidomastoid. And then the big trick here is to rotate the lateral side of the probe away from the clavicle. Initially, we started right behind the clavicle. We're going to rotate the lateral side until we get a good image of the rib. And this is not what I do. You're going to see this needle is a little closer to the probe. When you see my injection, I'm going to come back here a little further away from the probe. So we'll
you can see, Greg, you can see here, like if you come near the probe where this is taught a lot to go, at a steep angle, you're kind of aiming right towards the pleura here. If you come back from further away, it seems like it's even safer, where you're going to go shallower at your angle approach, harder chance to hit the pleura, which is below the clavicle. Is that true?
That you're exactly right, because you're coming in not only parallel to the face of the probe, you're coming in kind of parallel to the rib instead of going
like
at a steeper angle, angling more to the pleura. So you're exactly right. It's a very good point, Dr. Frankel. So I appreciate that. And I think we'll be able to see exactly what you're talking about on a couple images down the road. But you can see how on the left side of this image, I'm coming a little bit away from the probe, kind of flat, and that needle is going to be kind of parallel. So it's coming in more like this instead of a steep approach, where if you come up next to the probe. We want to identify the rib and the subclavian artery first. Exactly. And we want to identify those bad guys. And then we know we want to go after the good guys with our needle to get our local around our friendly faces around here, our smiley faces, and not down here. So, and then our first injection, like you said, we're going to come in. This one's a little bit steep, but that's to show we're going to go into the corner pocket just between the artery and the rib. That's where we want to make our first injection. That's kind of down under deep to the lower trunk, and that's going to lift this whole plexus up. And then we'll inject there. Then we can come back and get the rest of the plexus. Some people, especially if, like on the procedure I'm going to do, it's for an elbow surgery. And I just put pretty much all the local down here in this corner pocket in this lower trunk. And then if you're doing an upper trunk and on the thumb side, you'll come up here and get this upper trunk up on the upper level, or the more superficial side area of the block. So what do we use? What do I use for the block? Normally I'm using bupivacaine, 0.25%. We're using 30 cc's. You can use 0.5% if you want this block to last longer. Or ropivacaine 0.5%, 30 cc's. If you're wanting a shorter block, a faster onset, and a shorter block, which Dr. Frankel might want to use in the ER, he could use some lidocaine 2%. Still usually about 20 to 30 cc's. Most often we'll give the whole 30 cc's. It's really kind of a pretty safe block as long as you see that rib. Additives are common in anesthesia. There's a lot of talk about that. I used to use clonidine back in the 90s, buprenorphine back in the 90s also a little bit. Nowadays, on this block, we usually use 0.25% bupivacaine and 2 to 4 milligrams of dexamethasone in our block. We're usually given another 4 milligrams of dexamethasone IV to help with just post-op nausea and also for the anti-inflammatory effect. I'm not really been a user of dexmedetomidine, but some people have used that in their blocks also. Now, what are some of the complications, some of the risk involved with doing a supraclavicular block? Obviously a pneumothorax. And that's why we want to make sure we have a good image of that rib, because if you see the rib and see your needle, then you're going to be protected, because if you see the needle and the rib, they're going to be in the same plane, then the needle has to hit the rib and it won't get down to the pleura. Also, if you come in that flat angle instead of a steep angle, that's a little safer approach, obviously. Phrenic nerve block is a risk. It's about a 20% incidence with supraclaviculars. Horner syndrome, certainly you can get. I had my regional anesthesia fellow about 4 years ago. I did a supraclavicular block on her for her hand surgery. And of course, she's the one that ends up with the Horner syndrome. And it was very obvious. And she Still will give me grief to this day on that one. But
that's right. Doctors always get the worst complications. So
absolutely, as we all know, we've all been there, right? Recurrent laryngeal nerve block. You can get some hoarseness sometimes with a supraclavicular block. It's not anything significant. Just be careful. Tell them not to eat a lot of food in the next 3 or 4 hours. Hemothorax, and of course, local anesthetic toxicity is always a risk with any block, and we continue to aspirate no matter what block we're doing. I'm always using a nerve stimulator, and we're always aspirating every 3 to 5 cc's as we're doing our injections. So let's see how this procedure works. So this guy's having an elbow surgery. Got a chlorhexidine prep going there. I've got my probe there. We have our iPad now up here. We did see it down there on his abdomen, but I'm gonna put in a little local, a very small needle, just to put a little skin wheel, and I like to put it all the way up to the probe, a little local for our introduction. You can see on the right, you can see our subclavian artery here, our rib. It's dark below the rib, and you can perfect, and you can see our nerves. Our smiley face is all spread out over here. They can be anything spread out like that, or they can go up real tall. They can be in a different kinds of configurations. So here comes our needle, kind of flat. And what I want to do is just slide under these nerves right over the rib. And here we're advancing, just getting under the nerves at this point. And if I can, I'm going to slide on through. If I start getting a twitch and start running out of room, I'll start injecting and raise these nerves up. So you can see here the local starting to come in. That raises the nerves up off of the rib, gives me room to advance on into the corner pocket. So I'll put the first
pocket shot right there.
Yep. So here we are in the corner pocket, and we'll start that injection. You see the local spreading right there, pushing the artery to the left, pushing the nerves over to the right, and more superficial. There's probably 10 cc's so far. You can see I can just maneuver the needle a little bit up and down. We'll continue injecting. Now we got a good spread, actually, even between the artery and the plexus. So we've got like a U-shaped injection of local anesthetic kind of around this plexus at this point. Yeah, exactly. And then I'll come back. I'm probably going to put a little bit more as I pull back. I'm still down in the corner pocket. Okay.
And you can really see the needle better as you're adding the anesthesia. It really helps the needle kind of light up as it's bathed in fluid and not tissue anymore.
Absolutely. You usually see the nerves a lot better too once they have some contrast with the dark local anesthetic around it. Now I pulled back, did a little injection. We'll put a little bit up here on the upper trunk. I'm gonna come right under the upper trunk, between the upper and middle trunk. This comes with experience. You get comfortable doing this, and I can advance the needle. As you inject and open up a space, I do what I call hydro advancement and inject the needle into where the local is. So there's a nice view right there. You see the rib, the subclavian artery. There's the lower and middle trunks here. It's circled with local anesthetic, and then the upper trunk, kind of hard to see, but it's up in this area. So there we wrapped up real quick block. It worked really, really well. And then we'll move on to the next discussion.
The way you dissected the spread, one thing I've done with trainees when they're learning and, they don't go as fast and they're not as confident as you are with the needle, especially, is to use saline first. Open the space up with saline, because if they, there's an accident or it's going in the wrong place, the risk is much lower. And then you can dump the anesthetic into the space that you've opened up where you see the needle and everything much better.
No, that's a great idea for newer users and trainees. Good point. You just open it up, and like I said, I like to inject a little bit and then advance my needle into where I've injected that local. Or if they're not sure where they want to be, they can use that saline and open up that area and advance their needle. It's going to be safer. They're not going to infringe on the nerve or any vascular entities by opening it up like that. So it's very much a nice safety maneuver by doing that. It's a good point. So we'll move on to intra-articular injections of the knee. Now, this is something I actually do in the operating room. Almost all of our knee arthroscopies are done under general anesthesia. So we can do a knee injection right after induction. and it has time to work by the time the patient's prepped and draped, excuse me, and the surgeon gets started. So what kind of surgeries we do? Intra-articular injections, we use them with knee arthroscopies that are doing a debridement, meniscectomy, meniscus repair, chondroplasty, microvascular. Any of your basic simple knee arthroscopies is when I'm doing an intra-articular knee injection. So why do we do this? If we combine this with a multimodal approach, then we can decrease our post-op narcotics in the PACU, which decreases the multiple side effects you get from opioids, which will decrease our PACU time, increase our ASC throughput, increase our patient satisfaction. And it's really a low-risk procedure with a really high reward. Really, these minimal narcotics in our PACU when we do this, and we've had great results for many years. With my multimodal approach, we'll give us a gram of acetaminophen preoperatively, and under general anesthesia, we'll give some ketorolac, 30 milligrams, some ketamine, 15 milligrams. Like I said earlier, we really like dexamethasone for the anti-inflammatory effect, so 4 to 8 milligrams there in our intra-articular injection. We'll also usually give, with the induction of general anesthesia, a couple of cc's of fentanyl. And so you really have a nice multimodal approach, just using a small dose of narcotic along with our multimodal approach. So when we're given the Tylenol, we know that works centrally up in the brain. Ketamine works here in the posterior lateral horn of the spinal cord. Our dexamethasone and ketorolac are going to work down here on the as anti-inflammatories. And so with a multimodal approach, we're hitting different parts of the nervous system to prevent the pain from ever reaching the brain. And if we prevent these things from firing and prevent the spinal windup, which is a theory that's been published, then we can greatly reduce our narcotic needs in the recovery room. So opioids, we know they work on mu, kappa, delta, and sigma receptors. We also are aware that opioid receptors are out on peripheral nerves. So when we're putting it in the knee, in the joint, it actually works there in the periphery. So when we do an intra-articular injection of the knee, what are we using? I usually use 30 cc's of bupivacaine and primarily use morphine 10 milligrams. We've done this for years and years. A couple of years ago, we had trouble getting morphine, so I switched to meperidine, 100 milligrams. Meperidine, if you look at the chemical structure, is actually pretty similar to local anesthetics, and there's some thoughts that it may actually have some local anesthetic effect also. Now, our bupivacaine, I used to always use with epinephrine. We've had trouble getting bupivacaine with epinephrine in the last couple of years, so we're using it plain without epi. We use either one, and I like epi, but if we can't get it, we just use the plain bupivacaine. So that's what we're using on our intra-articular injections. So in the last 25 years or so, I've done close to 30,000 of these intra-articular injections on knee arthroscopies. We've seen no infections, basically no bleeding problems, issues, and no local anesthetic toxicity. So like I said, it's a low-risk procedure. One question I got asked one time was about the chondrolysis. And with this injection, we do it at induction. And so it's in the knee. They prep and drape. So 15, 20 minutes later, they're putting the scope in and they're washing away all the local anesthetic. The problem with chondrolysis happened years ago with continuous catheters doing a continuous infusion in the joint. Usually it was the shoulder joint, much smaller joint. And this continuous infusion for 2 to 3 days, that's where chondrolysis issues. We have never had any issues with chondrolysis or any problems with our cartilage in our knee arthroscopies. And like I said, probably 30,000 of these. So that's a good question, but it's really not an issue because we're not getting prolonged exposure to the local anesthetic. It's very short. So when we're doing it, we're going to look at the patella, and we're going to do our injection just here at the dot on the lateral aspect, superior lateral aspect of the patella. And to show you where we're really going, we'll look at it from this drawing. So the patella, we're coming up into this suprapatellar recess, just under the quadriceps tendon and between the femur and there in this area. So if you come over here, we're coming in laterally. You can see if we inject just in this area, that local is going to spread all down into the joint. It's going to be the menisci, the fat pads, and the ACL and PCL. So it gets a really good spread throughout the joint for about 10 to 15 minutes until they start the surgery. So here's our suprapatellar recess. Here's what we're looking at. You got our femur, our femoral fat pad, and just above that, we got the recess we're looking for to get into. And when you inject, you won't see this move much. It'll just, all the local will go down into the joint. Another picture, just to give you another idea of the little space we're looking at just above the femur, and we're just proximal to the patella. One more look, as again, you can see this one's a really small suprapatellar recess that we're trying to get our needle into, coming in from the lateral aspect. You can start injecting out here and then work your way in there if you need to. So here we go. So I've already got this knee prepped and draped, ready to go. Well, not draped, but prepped. And you can see just coming in lateral, again, flat, parallel to the probe. And see our probe is easy to use. You can see how the needle, should see the needle really well right here, coming in from the right side of the screen on the iPad.
Oh, yeah.
There we go. So we'll start injecting. And you really won't even see this local open up the space. You can see already I've got 30 cc's in there and it didn't open up at all. So you know that went in and bathed the joint really well.
It's a big potential space, right? So the suprapatellar recess just kind of, it's a good access point, and then it drains in, like you're saying.
Absolutely. And it's really easy and it flows right in. And if somebody has a big effusion, you can, it's really easy to see this, the suprapatellar recess will be wide open. And so it's really easy to see, but most patients are going to look like that.
You know, I'll emphasize this is something you can do on awake patients too. Like this is basically the gateway drug of ultrasound guidance for people who haven't done ultrasound procedures. You know, the knee is something we all learned in medical school to put a needle in blind and caused our patients a lot of distress and ourselves distress, scraping the patella, hitting the femur, trying to find the joint. And it's so satisfying to just glide in painlessly if you put a skin wheel on an awake patient. Whether you're aspirating or injecting, it's a game changer either way. So it's so great to hear you doing these. I haven't heard of many anesthesiologists doing knee injections, so it's pretty awesome.
This is not a common thing for many anesthesiologists, but I've been doing it a long time. I actually presented a paper on this at ASRA in like 2000 or 2001. And, but it's just my recovery room nurses, if we have like one surgeon that doesn't want to do it, they are all like, why can't you got to talk that other surgeon into doing this? We got to do it. You know, they really see a difference. And so I know it works just because they tell me.
Nice.
They make it very clear.
Yeah. And for people in an office practice, you know, putting other things like steroids or PRP or whatever else, you know, that they're augmenting for these injections is the same exact procedure, just with a different application.
Exactly. And it makes you make a really good point. This is a very common procedure from the OR to the ER to the office space. This might be one of the most common of all our ultrasound guided injections or aspirations for sure. Okay, so I want to talk now about a Pec One injection. And this is something actually I'll go to the recovery room and I'll explain why in just a second. And I'll do this sometimes. The Pec One is an injection between the Pec major and the Pec minor, and it blocks the medial and lateral pectoral nerves. The medial and lateral pectoral nerves are branches off of the medial and lateral cords. So an interesting aspect of the anatomy is the lateral pectoral nerve actually comes a little bit more medial and superior than the medial pectoral nerve, which comes a little more lateral and inferior. And then why is it named that? Because the lateral pectoral nerve comes off the lateral cord and the medial pectoral nerve comes off the medial cord. So it's kind of an interesting anatomical situation from the naming standpoint of those nerves. But you can see the Pec major is cut here. The Pec minor is kind of gone. So we're going to be in between those two nerves. We'll get a better look at that in just a second. So why do we use Pec One injections? Surgeries basically involving the Pec major muscle, breast expanders, subpectoral prostheses, pacemakers, portacasts. But something we've discovered is a shoulder surgery with a biceps tenodesis. We'll talk a little bit more about that and give more explanation. Also, Pec One is added to a Pec Two for mastectomies, wide local excisions of the breast, sentinel node biopsies, and axillary surgeries. So what I noticed a few years ago, 3 or 4 years ago, the patients having a biceps tenodesis would get in the PACU and they would have severe pain in the axillary region, in the axilla. And it was where the incision for this biceps tenodesis was. We did preoperatively, we were doing interscalene blocks and catheters. So they had no shoulder pain. They were fine from the shoulder, but they're really struggling with this axillary pain. So one day I said, I'm going to try a Pec One and a Pec Two and see if those blocks will take care of this axillary pain that they're having. Well, I did the Pec One and boom, the pain was gone. I didn't even proceed and do the Pec Two part of the block because they were doing fine. We did several of these, and then we decided we wanted to publish this and try to publish with this through the ASRA Journal. Didn't get a lot of cooperation, so we kind of punted that. But while we were doing our research, we found one article where the guys at Wake Forest, they were using Pec One and Two for the same thing, for biceps tenodesis. And so you're trying to think, well, we've already got the pectoral nerves blocked with our interscalene block coming off the cords. So their theory was this spread from the Pec One goes laterally to the intercostal brachial nerve, which we know is T2, T3, mostly T2, comes into the axillary region and does the skin, superficial areas. And so it makes a lot of sense to me, made a lot of sense that's how this was working. So we'll look at this again. So we're injecting in this area, kind of lateral area of the region between the pec major and minor, and that intercostal brachial is right in here in the axillary region. So this spread could just spread laterally and get to that intercostal brachial, and that's the theory of why we think this is actually working. So it's a real simple block. You just get as lateral as we can between the pec major and pec minor, and 10 cc's of 0.25% bupivacaine is all we need to do this block. Another pretty simple procedure, and of course, pulse ultrasound makes it much, much easier and plainer to do. So pec major, pec minor, just get in this plane, come out a little lateral, and that's what we're looking for. It's an easy approach. The anatomy is very easily identified on ultrasound. The pec muscles are pretty easy to see. It's basically a plain block. And this is an interesting block because you can actually approach it from superiorly or inferiorly. So you can start superior to the probe or inferior to the probe. I like to go superiorly mostly, but sometimes I'll come inferiorly depending on my view and how things look. Minimal risk is if you're just careful and watch out for what you're doing and put it in this plane. So here, as you can see, an ultrasound image, the pec major, the pec minor. I usually want to go deep enough. If you see the subclavian artery down under the pec minor, you know you can see the pec major and the pec minor really well. The thoracoacromial artery is up here, and that's an area I kind of shoot for. I kind of drop a little down, a little local around that, and also in the plane between the two muscles. Another picture, this time it's not labeled, just so you can look at it and see for yourself the pec major, the pec minor, subclavian artery here, and thoracoacromial artery right there. Those are kind of basically your anatomy. That's what you're looking for. And this is another view, and just to show you the clavicle, I got up a little higher, a little more cephalad to see the clavicle, so you can get an idea of where you are. So that's why sometimes it's hard to come from superior, and a lot of people like to come from an inferior approach and get in this plane and inject right through there. It's kind of like doing a tap block, really. That's just another, shows I put a little local down in here around that thoracoacromial artery. And here we go. So again, now I want to show you, see, I got my iPad right here on the patient, laying it just on the patient's abdomen. And I come in, this time I'm coming in from an inferior approach. See a nice big pec major here. And we have our probe here. It's real easy. There's no cords, no cables coming off of it. So we can make a nice approach, get a nice view. And you got your line of sight, you got your needle and your iPad right there all lined up so you can see everything as you're approaching, with some nice ergonomics with that being able to put your iPad wherever you want it. I use a mini iPad, so it works great. So you can see our needle coming in, and you can see the pec major trying to get in this plane right in here between the pec major and the pec minors down here. It's a little deep. I don't see the subclavian or the subclavian artery very well. I'll show it here in a minute. I think I get deeper. So we will start injecting. You see the space right here opening up between pec major.
That might be the artery.
There's the artery. Yep, you got it. Now you can see the space opening up right here between the two muscles. You see how easily it is just to move that probe around and keep a good view.
It's pretty great to have the screen so close to your line of sight. It might make it, then it's just your eyes moving. You're not kind of tweaking your body around, and you can really keep your eye where
that's a perfect shot right there to show it too. You can see the and then reach up. I can add some depth. It was real easy. You change the screen. I wanted a little more depth to show that subclavian artery. So you just touch the screen. It's so easy to change your view. You can change the game by just swiping to the right and left on the screen. There, I'm showing where the biceps tenodesis incision is going to be right there in the axilla. And so that local spreads over here to get to that intercostal brachial nerve. Yeah, that's a great view right there, actually, just to see. Okay, so just to review some of the important takeaway messages from this talk is one of the things I do, maybe a little different from a lot of people, is I start my needle insertion a little further away from the probe that allow me to see the probe in plane a little bit better, because it's going to be parallel to the face of the probe, and you get a better reflection of the needle versus coming in at a steep angle where it's a little bit harder to see. And the ultrasounds, they have ways to help you and assist you, but to me, I never use that kind of thing because I've always got the needle flat and I can see it really well. Number two is I use a little bit longer needle, so that allows me to be able to start farther away from the probe and then get better imaging. When I'm doing a supraclavicular block, got to identify the first rib. You got to identify the first rib and the subclavian artery, and then it's pretty much a piece of cake from that point on. With the intra-articular injection, it's just part of our multimodal analgesia to minimize our narcotics and get the patients out of our PACU and out of our surgery center quicker and more comfortable. So and it really has worked well in my practice over the years. And then the big reason I use the Pec One of the most common things in our practice, because we do a lot of shoulders, and for some reason the biceps tenodesis has become a lot more popular in the last 4 to 5 years, I would imagine. It's just a lot more than we used to do 10 years ago, for sure.
Great.
And since I'm down here in Gulf Breeze, Florida, basically I'm in Pensacola, Florida. Gulf Breeze is just outside Pensacola, a little closer to the Gulf of Mexico, and it's the home of the Blue Angels. So these guys fly right by my house, usually every Sunday night as they're coming home from doing a show wherever. But then in the second weekend of July, there's always a big show out on the beach, and there's about 8 million people hanging out around my house. And so I took this picture one day, and I just love the Blue Angels down here.
That's awesome. Well, thanks so much, Dr. Hickman. That's pretty great. We have time left, and please use the Q&A box in the bottom to record your questions. We're going to make sure to have time at the end to get to all of your questions, as many as we can. We're going to kind of wrap it up here, and I'm going to hand this back over to Janez in a minute. Thanks so much for sharing your wisdom. And I really want to reiterate, with this kind of changing of the guard, so to speak, and the introduction of the handheld probes, it really takes a lot of these procedures even outside of the operating room, where we used to have to rely on carts. Now we can take these into ambulatory care centers and even into the field, rural and remote areas. Opens doors for regional anesthesia everywhere. And we just find that the applications are almost endless, and the ability to improve patient care everywhere is pretty remarkable. as we're watching the field evolve. And so, you're really a front runner in the field, and we can't wait to see what other things you come up with and what some of our viewers may develop in the future. So we look forward to listening. I'm going to hand it back over here to Janez for a few minutes, and then please stay tuned and we'll get to all your questions at the end. We're with you until the end of the hour. So.
Thank you, Dr. Frankel, and thank you, Dr. Hickman, for all your ultrasound imaging strategies for effective regional anesthesiology procedures. I'd like to now just take a minute to share a video that we captured with Dr. Frankel to give you a first look at our improved Clarius Needle Enhance 8.0 software that we released last week, which is particularly useful for more novice ultrasound users. Needle Enhance is an upgrade option that's available with Clarius scanners that leverages artificial intelligence to light up your needle during ultrasound-guided procedures. Let's start the demo.
When doing nerve blocks or musculoskeletal procedures, Needle Enhance can help my needle light up all along the shaft and identify the bevel in the screen. With Needle Enhance, I can watch my needle come in and light up even when it's not an echogenic needle, and see it really approaching my target just prior to injection. It's important that the needle icon on the screen matches the direction that the needle is coming in from. If I was coming in from the other side, I would flip the icon to the other side, and you can see it loses Needle Enhance coming in from the opposite side. Using Needle Enhance helps improve patient safety and accuracy by identifying adjacent structures and ensuring my needle was in the appropriate location during the procedure.
As you just saw, Clarius Needle Enhance improves visualization, lighting up your needle for easy identification, while the Clarius HD scanners deliver high-definition imaging of the surrounding structures for clear visualization of your injection target. With higher frame rates, now up to 30 frames per second, we see angle sensitivity and crisper needle imaging with 8.0. Our software uses AI and a multi-angle approach, automatically optimizing the image in real time for your acquisition angle, so there's no need to set or manually adjust the angle. All of this for faster visualization, of course, during your busy procedures. Now, before starting our live Q&A session shortly, I would like to take one more minute to introduce you to Clarius HD, our line of high-definition wireless ultrasound scanners. Clarius linear scanners are designed for anesthesiologists to deliver several advantages. Clarius is unrivaled for near-field and high-resolution imaging in a handheld device. This best-in-class imaging is what you need for clear visualization. As you saw today, you get a clear view of tiny nerves, vascular structures, tendons, and so on for safe ultrasound-guided injections. The secret lies in each scanner with 8 beamformers that deliver the image quality only found in traditional systems, but at a fraction of the cost. And with artificial intelligence to replace complex knobs and buttons, it's as easy to use as your smartphone. Clarius is also wireless, freeing up space with zero footprint for portability in a variety of settings. You get free movement with no more wires getting in the way or touching your sterile prep area. With no wires, Clarius is also so much faster to clean, disinfect, or fully encase in a sterile bag. Only Clarius delivers wireless scanners with a free ecosystem that includes free apps for your iOS or Android devices with free updates, unlimited cloud storage to capture and manage exams, and for unlimited users at no additional cost. Clarius is so affordable as well with no subscription fees. You can use a single device and sharing among physicians in your practice, each of you with your own mobile devices, wirelessly synced to the scanner. Now, just before we open the floor to questions with Dr. Frankel and Dr. Hickman, here's a quick poll for you. We'd love to help everyone continue on their journey in bringing handheld ultrasound guidance into their practice. So please go ahead and select any of these options that you see here. You can book a Clarius HD demo where we will do live scanning for you. You can request a quote and pricing. We've got people joining us from all over the world today. We do offer our products in 95 countries in various different currencies. So go ahead and select that if you'd like to know about local pricing. If you'd like to talk to one of our experts to discuss features, we'd be happy to do that with you as well, or just have a discovery call with an expert to learn more about the advantages of a handheld system, or you can watch more tutorials. We've got a number of Clarius classroom tutorials available with a variety of different Pec and pain medicine injections that we can share with you. So go ahead and select that option if you wish. I'll just give you 5 more seconds here. There's so many votes coming in. 5, 4, 3, 2, 1. If you didn't get a chance to complete this poll, you can also request more information on our website at www.clarius.com. Now, just before we go to the live Q&A, there's one last poll. I'd like to extend an invitation to our next webinar. With this final quick poll, you can save your seat for our June 15th webinar, entitled Focus for COVID and Beyond, Diagnosing Lung, Cardiac, and Thromboembolic Diseases. While we covered ultrasound for injection guidance today, there's a push to incorporate whole body focus into daily practice amongst anesthesiologists, including pulmonary and cardiac scanning. Our next expert guest speaker, Dr. Arishenkov, will teach both basic and advanced POCUS applications to confidently diagnose pulmonary and cardiac diseases, including diving into pleural line abnormalities, focused cardiac scanning, and also DVTs. Save your seat with this poll, and we'll send you your registration confirmation by email in the coming days. I'll give you 3 more seconds to save your seat. 3, 2, 1. Now on to our live Q&A. I'd like to welcome back Dr. Hickman and Dr. Frankel to answer your questions. Please use the questions icon in the menu bar to ask your questions of our great doctors. We've got lots of good questions that have come in already. At any point during this live Q&A, please go ahead, use the Q&A box to ask your questions. I'll invite Dr. Frankel back to moderate the live Q&A.
Great, thanks, Janez. And yeah, there are a lot of questions here. We'll get to as many as we can. If we don't, we will follow up with answers. So we'll make sure everyone gets their questions answered. Okay, first question for you, Dr. Hickman. A lot of people want to know, how do you sterilize the probe and your iPad between users?
Right. So as Janez just talked about there, you actually have probe covers you can use. I don't use the probe covers. We have the wipes, the non-alcoholic wipes that are to sterilize the probes that we use between each patient, and then just wipe off the iPad real quick. You want to make sure don't use an alcohol solution on your probe. That's not good for your surface of your probe. So we just do that.
In the era, I would add in the era of COVID too. That's what we're doing. We use chlorhexidine wipes on the probes between users, and seems to be kind of the standard. People also want to know, how do they learn more? How do people learn more on how to do more blocks and be more proficient at doing them?
So we talked about this the other day. People ask me, what textbooks to use, and really textbooks are totally irrelevant when it comes to this kind of practice. So there's lots of good websites out there. There's several good sources. I have our website, blockjocks.com, is one that has a lot of good videos and a lot of good speakers. There's several other websites, Nisora. I used to like the one out of Canada, out of the other side of the country from you guys, usra.ca. And I use that a lot. There's you can Google, you can find several good websites with videos and educations and tutorials, and even just YouTube. I know I used to have stuff on YouTube, and people watch YouTube.
Yeah, it's a quick and easy way especially when you're on the job.
Right.
So I'm going to try and combine a few of these questions together. I figure maybe this doesn't apply, but people want to know, do you do any perioperative ultrasound? It's a thing for, I guess you're doing mostly orthopedic procedures.
A lot of orthopedics, yeah, primarily orthopedics.
Okay, I guess perioperative ultrasound would be more in the realm of doing, general surgery or thoracics maybe. There's certainly a role and a growing literature around it and training anesthesiologists to do it. The linear probe would not be your probe of choice for that. You would have to use a phased array or a curvilinear probe like we do in emergency medicine or critical care. And that would get you, excellent cardiac and abdominal organ scanning, but a bit of a different application. But certainly within the wheelhouse for anesthesiologists.
Absolutely. Some anesthesiology in a hospital setting where you have sicker patients and other things you want to evaluate. I'm in an outpatient orthopedic setting, so I don't really do that kind of a practice.
How would you compare the image quality of the Clarius handheld to traditional carts?
Great question. It's really close. I think, as you can see, well, maybe you can't see on this, but if you get it and try it, I think the image quality is much better than it was when it started out. One thing I can say, I've been using the Clarius since it first was available, maybe even before it was available, but I probably shouldn't say that. But I have seen tremendous improvements, and when I've made suggestions, they've been Clarius has gone to the drawing board and really tried to work with things, and all the options that we're constantly getting upgrades, and I've been impressed with the image quality. It's very good.
Great. And this is connecting to a question I had for you, but a couple of the viewers as well. You know, in a previous conversation, you mentioned that handheld ultrasound can be used for what you guessed was about 70% of regional anesthesia procedures. So what are some of the other procedures that you're using the wireless ultrasound for that we didn't get to today?
Well, it's you can use it for femoral blocks, for adductor canal blocks, which are real common in regional anesthesia, but pretty much anything. One thing, I love the mobility. If I need to go over to PT, we do a lot of continuous catheters. And so if we have a catheter that the patient's in PT the following day or 2 days later, and they're not doing as well, we can go over and just check the catheter location. It's real easy. Just inject some local through your catheter and see if the spread is around the nerves that you need it to be. And it's just so easy to grab the iPad and the probe and walk over and go take a check. It's real quick and real easy to do. I love doing that. The mobility of that, or in the PACU, if the patient wakes up and we have a catheter in and they're not doing as well as we think, we can just walk right over and look in the PACU and check our catheter location. That's something we do commonly.
Nice. Maybe a content specific question. Do you combine those intra-articular knee shots with blocks as well, or are you just sticking to the intra-articular?
As a general rule, and it depends on your procedure, for just knee arthroscopies, we just do the intra-articular injection. With an ACL, we don't do the ACL or a total knee. We don't do the intra-articular injection. Then we do the adductor canal, an IPAC block, and a lateral genicular block, and that combination works much better for those cases. The intra-articular is more for the simple, straightforward knee arthroscopies. I think there was a question about somebody said their surgeon did it at the end of the case. What we've actually, the study I did 20 years ago, we found much better results if you do the preemptive injection prior to the surgery versus at the end of the case. The injections the surgeons did in our study didn't work nearly as well as doing a preemptive block before the surgery.
Nice. And that was a pearl there. I've always heard about the chondrotoxicity of intra-articular anesthetic. So that's a good point, that this is different than someone like me injecting anesthetic and it sits in the joint versus just doing it pre-op and then they're going to go in and wash everything out. It's kind of you have a better deal on that than I do.
Yeah, a little safer on that track.
Yeah, for sure.
Yeah.
Great. I think we have time for one more question. There's so many, it's hard. Some of them are pretty specific. Let's see. It's a good one. We did the learning. Oh,
let's see. I'm looking at them.
Is there one you want to answer?
Yeah, side effect is a good question. Are there any side effects associated with intra-articular morphine? It's kind of interesting. So if I have a patient that says, "Oh, I'm allergic to morphine," and what happens when I get nauseated? Well, yeah, that's pretty common, right? Or I have a little pruritus, itching. I'll still do it because they're really not getting absorption of the morphine. It's going in the joint, and then it's getting washed out. So they're not getting enough absorbed. They're getting enough to get in and bind to those narcotic receptors in the nerve endings in the knee, but not enough to really get absorbed to have significant side effects. So I really don't worry too much about that. I rarely don't put morphine in the knee when I know it's going to get washed out just a few minutes later. So that's a good question.
Great. And there's more good questions. I'm sorry, I was scrolling and trying to find them. We'll get back to you at the top of the hour. We're respectful of your time. We will get everyone an answer who provided a question. We'll follow up with you. So thanks so much for your participation, and thank you, Dr. Hickman.
I see one question about cardiac POCUS, and I would say just come watch the next webinar, and there you should get your answer on that one, right?
There you go. Thanks. It's my line. Yeah, I appreciate that. Absolutely.
We definitely
Thanks,
hope
guys.
to see you next month. We have reached the top of the hour. If we didn't get to your question, as Dr. Frankel said, we'll email you in the coming week. I will also want to note that you will all receive a copy of the PDF slides that you saw today, as well as a recording of today's webinar. I'd like to thank Dr. Frankel and Dr. Hickman for all of their insights, and a very, very big thank you to all of you for joining us today. We do hope to see you again in exactly 1 month for the webinar POCUS for COVID and Beyond, diagnosing lung, cardiac, and thromboembolic diseases. In the meantime, I hope you have a wonderful rest of your day. Thank you so much for joining us.
Cheers.